The increasing beauty of this meeting. So it's lovely to be back. So Hesham gave me a title of discussing triple-negative breast cancer that is easy and difficult. It's easy because there are really no large randomized trials, so there's basically no data, but it's difficult because there's no data. So I would like to share with you within the next 20 minutes, briefly, discuss the subtypes of triple-negative breast cancer with you, evaluate or look at the targets, and also available current clinical data. The advent of molecular or gene profiling really enabled us to identify molecular subtypes of breast cancer. And related to our topic today, here we see that ER-negative, PR-negative, and HER2-negative molecular subtype, most of those actually fall into the basal-like molecular subtypes. This subtype is further characterized by being CK5 and 6 positive and or EGFR or HER1 positive. Furthermore, recently, another subtype, molecular subtype of triple-negative breast cancer has been identified, even though the fraction of it, as you can see here, is very low, the Claudin low type. As I mentioned, it's only 5 to 10% of these tumors. It carries a poor prognosis and has some of the stem cell features. It is characterized by having low expression of cell-cell proteins, and also histologically, when pathologists evaluate it, they report more lymphocyte infiltrate. And very early data shows that maybe this subtype is associated with more residual disease after chemotherapy. But as you can see from this graph, it really is one of the rare subtypes, but that carries a more poor prognosis amongst the triple negatives. The other characteristics, for example, in terms of histology, even though generally we know triple-negative breast cancer as high-grade, very aggressive, however, it can actually range from low to high-grade. For example, there are some triple-negative breast cancers that are characterized in the secretory carcinoma, adenocystoid carcinoma, even medullary, and then going again to the high-grade side, invasive ductal, which is the most common, and then even metaplastic carcinoma, which is more rare, but again, most of them are triple-negative. In terms of epidemiology, we are getting more and more information from recent publications that obviously we see it in younger patients. When we look at the data in the States, more prevalent in African American and Hispanic young women. We really don't know about the risk factors for triple-negative breast cancer at this time, nor we do the risk factors for ER-negative or ER-positive breast cancer either, but we don't know it for triple-negative breast cancer for sure, except that very recently some observational studies suggest that amongst African-American women who do not breastfeed, those tend to have more triple-negative breast cancers. But this is all early findings and certainly needs validation, especially in other ethnic backgrounds. In terms of diagnosis, again, studies recently suggest that lower proportion of triple-negative breast cancers are discovered by mammograms. However, this could be also related to the age distribution because in general, lower proportion of cancers are diagnosed on mammograms in younger cohorts, and perhaps it's related to that rather than the biology. We know that clinically that these patients have a rather aggressive course of disease. There is a high recurrence rate within the first, but especially the first 2 years of this disease. One prospective cohort of about 1,600 women were evaluated. Amongst those, 11.2% of patients were reported to have triple-negative breast cancer, about 180 patients. and the rest of the cohort, 1,400 patients, were non-triple negative. As expected, a higher proportion of patients, close to 50% of the triple negatives, received chemo, whereas in that cohort, only 1/4 of the non-triple negatives received chemotherapy. The median follow-up of this cohort was 8.1 years. The cohort showed that in the triple-negative patients, the age of diagnosis was slightly, however, significantly younger compared to the non-triple negatives. There were also, as expected, more, about 66% grade 3 tumors compared to only 28 in the non-triple cohort. And again, when we look at the tumor size, there were more smaller than 2 centimeter sized tumors in the non-triple negative versus only 1/3 in the triple negative were smaller than 2, so they were larger tumors. And the same again, node positivity was seen higher in the triple negatives, about 55% versus 45% in the non-triple negative cohort of that cohort. When we look again in the study in survival data, risk of recurrence as well as risk of death. So especially the risk of that in the triple-negative breast cancer cohort, so amongst these 180 patients compared to the 1,400, there was a 3.2 times higher risk of dying from disease if you were triple-negative versus non-triple negative. And also another hallmark, I think, we now see in our clinics also, once there is recurrence, so once metastatic disease is diagnosed, the time from metastatic disease diagnosis to death is also significantly shorter for triple-negative breast cancer patients. And again, in this particular study, median time to death from recurrence in the triple-negative cohort was 9 months versus 20 months in the non-triple negative group with a significant p-value. The BRCA population is has a special relation with triple negativity. When we, for example, look at women diagnosed with breast cancer, triple negative breast cancer before age 50, about 25% or even 27%, based on our data, of women actually have a deleterious germline mutation in the BRCA1 or BRCA2 gene. So there's certainly at least the BRCA-ness-like entity in triple-negative breast cancer, and then also patients who have a mutation. So in one study, what we wanted to do is to look at the outcome of triple-negative breast cancer patients and see whether being BRCA positive or negative had an impact. So at the time of that publication, we've had 227 women with triple-negative breast cancer who were referred to our genetics counseling clinic and who underwent BRCA testing between 1997 and 2010. We have more patients, but that's data from 2010. And as I mentioned, we had about 25 to 27% of BRCA positivity. And we were going to evaluate outcome in relation to BRCA positivity or negativity. Because of the interest of time, I'm immediately cutting to the final slide, the results. And in our cohort, having a BRCA germline mutation did not make a difference in terms of overall survival in this triple-negative cohort. And again, because I slipped many of the method slides because of the interest of time, these patients were treated the same because they were seen in the same time frame with our standard adjuvant or neoadjuvant trials consisting of anthracyclines and taxanes. And once they had recurrent disease, again, they were treated in the same algorithmic order for metastatic breast cancer. So what I would like to do in this next segment is review with you the data regarding chemotherapy, because the question is, should we treat with our current knowledge triple-negative breast cancer patients different than our other standard patients? And the data I will review with you, unfortunately, does not include large prospective phase 3 data, but I will review with you what's available in terms of phase 1 or phase 2 data. I think it really makes sense to start with the anthracyclines because it's one of our gold standard agents in the adjuvant setting. And again, I would like to point out that in many of these studies, the triple-negative cohort here was done in a retrospective analysis. So these studies were actually not designed to look at triple-negative breast cancer outcome, but the authors went back and did some HER2 testing and evaluation of marker status and carved out the triple-negative cohort. For example, DeLeo, in his phase 3 study where anthracyclines versus CMF was used in the adjuvant setting, they were able to identify in that cohort, out of that big cohort, 157 triple-negative patients, and again, in an analysis that was not prospectively statistically planned, there was a 23% reduction in risk of relapse if the triple-negative breast cancer patients received an anthracycline instead of a CMF. In another study, a small study, phase 2 study, with 120 patients, in the neoadjuvant setting, patients received CEF for 4 to 6 cycles. Again, this was the sub-cohort of the larger study, and the PCR rate was 17%, so there is certainly some activity. And Glutz et al. Looked in the neoadjuvant setting in a study where they were comparing dose then EC or CMF to high-dose EC and then EC followed by thiothepa, a regimen that I think we don't use very often, and then they were able to carve out 66 patients that had triple-negative breast cancer, and they reported that the 5-year event-free survival was actually pretty high, 71% for high-dose EC and EC followed by thiothepa. I think, as I mentioned, these are small studies, but the take-home message is that the anthracyclines are effective, actually, for the treatment of triple-negative breast cancer. So then, how about some studies looking at the anthracyclines and taxanes? This is a study from our institution, and I'm showing this because it has a rather larger cohort. We looked at about 1,100 patients who received neoadjuvant chemotherapy with anthracyclines and taxanes for stage 1 to 3 breast cancer. And we've had a rather little bit higher than reported in the literature, triple-negative disease rate, about 23%, 255 patients. But that's also referral bias, because when patients are diagnosed on a core biopsy with triple-negative breast cancer, they tend to come to us for trials. So certainly the triple-negativity rate is not as high as 23 in all-comer breast cancers. And when we looked at some our outcome data, patients with triple-negative breast cancer, interestingly, even though they were treated as the non-triple negatives with anthracyclines and taxanes, had a higher PCR rate, so 22% for the triple negatives versus 11% for the non-triple negatives. However, as a paradox finding, they've had actually increased risk of visceral metastasis and also a decreased 3-year progression-free survival and overall survival that was statistically significant. So how does this happen? Our triple-negative patients have a doubled PCR rate, and we now know from many studies, including the NSABP studies, that a pathologic complete response rate actually could be used as a marker for long-term outcome. However, in our cohort, a higher PCR rate did not translate into improved survival. But when we look at the data a little bit more careful, we can actually explain why. So here are the 4 curves for overall survival that includes patients achieving a PCR that have no triple-negative breast cancer, patients that are achieving a PCR that have triple-negative breast cancer. The dotted line is patients who have residual disease, non-triple negative, and then the red line here is patients who have residual disease, so no PCR with triple-negative breast cancer. So when we look at the triple-negative breast cancers that achieve a PCR, they actually do very well. The ones that drag the the curve down is actually the patients who don't achieve a PCR and have triple-negative breast cancer, they do worse. So the point here is that I think we have to find effective treatments that improve the PCR, and the neoadjuvant setting is, I think, a very nice biological model to evaluate agents and targeted agents and endocrine agents to report or achieve and evaluate a PCR that hopefully will then translate into long-term outcome. There have been also other studies, again, subgroup analyses, retrospective, not planned prospective analyses of available cohorts to see if the addition of taxanes was helpful in triple-negative breast cancer. So again, look at this data with caution, please. But I think it supports the previous studies that, for example, in the CALGB C9344, which was, as you know, a large randomized study looking at AC versus AC with adding paclitaxel, when the authors were able to go back and retrieve some of the tumor blocks and do ERP and HER2 again, in the HER2 negative and ER negative group, the addition of paclitaxel was able to improve the outcome in these cohort. However, you can see in the ER positive and HER2 negative, there was no benefit from paclitaxel. Interestingly, in the HER2 positive patients, and again, these patients were not treated with trastuzumab, the addition of paclitaxel was helpful regardless ER status, but that's another category, not for today. But again, cautioning you that these are not planned prospective analyses. Then the same thing was done with other known adjuvant trials, the BCIRG study that compared TAC to FAC, this large study, 001. The authors were able to evaluate HER2/neu and have the status available in a subgroup of patients in 192. And again, there was a borderline improvement in outcome for this triple-negative cohort when TAC was used versus FAC. And there's another study that is not very often quoted that looks at AC followed by paclitaxel versus AT followed by paclitaxel. And again, when they were able to carve out the triple negatives from this cohort, there was a benefit when the patients were more treated with the taxane. Again, cautioning that these are retrospective analyses, but all promoting the notion that anthracyclines and the addition of taxanes is helpful in the triple negative cohort as well. However, as I had mentioned in 3 prior slides, that we really have to most probably cannot stop and be happy with anthracyclines and taxanes alone because we have to improve their either PCR rate or their cure rate. So what other agents have been looked at to further improve on the outcome of triple-negative breast cancer patients? I will not be able to review all of the agents, obviously, in 20 minutes, but I will touch base on a few. But the agents that are in question and are being studied includes the platinums, capecitabines, vinorelbine, nab-paclitaxel, liposomal doxorubicins are agents, ixabepilones, eribulins, and other targeted agents, bevacizumab, PARP inhibitors, EGFR inhibitors, etc. And so I'll give you a few examples. And again, for the interest of time, and because it will be also boring, I will not go through every single phase 2 small study with 20, 30 patients, but give you rather an overview. For example, these are the studies I could find that have a reasonable N number that evaluated platinum agents in triple-negative breast cancer. Most of the studies, 3 of them were done in the neoadjuvant setting. For example, one study in a cohort of small 30 patients in the neoadjuvant setting, and again, the study was not designed to look at this, but it was more prospectively all comers, and they carved out the triple negatives, where, for example, patients received epirubicin cisplatin 5-FU, then followed by paclitaxel. Again, the idea is incorporating the platinums. The PCR rate was actually not bad, 40%. In a second smaller study, patients received only single-agent neoadjuvant cisplatin that was published in JCO 2 years ago. 22% response rate is actually, again, not bad for a single-agent cisplatin that does not contain an anthracycline and taxane. And a larger study, which was retrospective, neoadjuvant, evaluating platinum plus docetaxel, reported a PCR rate of 34%. Again, not very bad. And then finally, a very small study in metastatic triple-negative breast cancer compared carbo plus paclitaxel versus cis paclitaxel. And then the overall response rate was 37.5%. So certainly the platinums do have activities. However, the question is how to incorporate them prospectively into our current regimens. And obviously, we need phase 3 data. The other area that is being looked at for triple-negative breast cancer in terms of targeted management is, does bevacizumab have a role? And again, I have here studies that are large prospective studies, and then they carved out the triple-negative cohort out of those studies. For example, in the E21-100, as you know, the study evaluated paclitaxel versus paclitaxel plus bevacizumab. The addition of bevacizumab in the triple-negative subgroup improved the median survival from 5.3 to 10.6. The Avado trial, again, a taxane plus minus bevacizumab, the addition of bevacizumab improved the median progression-free survival from 5.4 to 8.2 months. And in the Ribbon trial, Ribbon 1 trial, as you know, there were taxanes plus minus bevacizumab, capecitabine plus minus bevacizumab. Unlike the first two other studies in the triple-negative subcohort, but small number of patients, the addition of bevacizumab to a taxane did not make a difference. However, in the capecitabine group, the addition of bevacizumab improved the median progression-free survival from 4.2 to 6.1%. Obviously, there are no p-values associated with this, but one hypothesis was also that capecitabine is actually a single agent in triple-negative breast cancer, is not really sufficient and active. That was another byproduct, and the improvement really came from the bevacizumab. And there's another study, Athena, that was again a taxane-based study plus bevacizumab, larger cohort, and the median progression-free survival was 7.2%. So bevacizumab also has some activities, but again, prospective large studies are needed to see how you can incorporate this into your current regimens. In terms of another targeted approach, epidermal growth factor receptor inhibition for triple-negative breast cancer, we again don't have major studies. Two studies actually with a small cohort. One was run by the TBCRC, the Breast Cancer Research Cancer Group, where patients received cetuximab plus minus carbo. So everybody got the EGFR inhibitor, and then one group got carbo. The overall response rate was 6% versus 18%, clinical benefit 10 versus 27. And the study didn't really continue because the efficacy was really low. This is in the metastatic setting, and as you can see, these patients were treated previously with anthracyclines and taxanes. O'Shaughnessy did a study looking at irinotecan and carbo plus minus cetuximab. The overall response rate with the addition of cetuximab improved. They did not report the clinical benefit rate, and progression-free survival very minimally, almost did not change. So again, I think hypothesis generating that adding targeted agents to chemotherapy might be beneficial, but needs to be further evaluated. So there are certainly other targets that we don't even have this much data on, but just to point out that is ongoing. For example, VEGFR is still a target for triple-negative breast cancer. There are some studies now going on with sunitinib, targeting angiogenesis with agents such as endotag-1 and metronomic chemotherapy. As you know, that's being done, especially in the East Coast and Sloan Kettering, looking at metronomic chemo. Apparently, it has angiogenesis inhibitor effect. SRC is a pathway that has been now shown in preclinical and animal models to be involved in ER-negative and triple-negative breast cancer development. So it's in the pathway. And we do have SRC inhibitors now that are clinically available. And one study is going on with dasatinib, looking at the activity of it in triple-negative breast cancer. There are other targets such as checkpoint kinase 1, UCN01 is targeting it. I think we are all more familiar with mTOR pathway that is involved in triple-negative development, and also the agents that can block it, RED01, everolimus, temsirolimus, are all being looked at. Interestingly, a very small proportion of triple-negative breast cancers were about, I want to say 5 to 10%, were shown to have an increased androgen receptor. Even though when you look at this, the overall proportion of androgen receptor positivity in breast cancer will be then very low. But there are some small studies going on with bicalutamide to look at the suppression. TRAIL pathway is being looked at, TGF-beta is being looked at, and the platelet-derived growth factor pathway, c-KIT pathway with imatinib are being looked at. I think we have a little bit more information about DNA repair pathway agents, such as PARP inhibitors, and I just want to give you a very brief example of that. As you know, the PARP is a key regulator of DNA damage repair process. It's involved in DNA base excision repair, and it directly binds to DNA damaged area, and it produces these large branches of PAR. And then what it does is, once it does it, it attracts some of these base excision repair effectors to the site, and then the damaged DNA is repaired. Here I summarize some of the phase 1, phase 2 PARP inhibitor trials. This is a mixed cohort. One cohort, this one, for example, is purely done in BRCA positive patients. However, amongst those, 50% have triple-negative breast cancer. And the olaparib, for example, is an oral agent with some 41% activity. So as a single agent in heavily pretreated patients, 41 is not bad. A phase 1 study looked at BRCA patients also and did not report on triple-negative breast cancer patients, but there was a 63% clinical benefit rate.
Professor Aron, please, time.
And then the ABT 888 with temozolomide also looked at BRCA patients. 56% had triple-negative breast cancer, and the response rate was 37.5%. This one study I think is very well known to you with BSI, gemcitabine, and carbo plus minus BSI 201, which is actually another PARP inhibitor, is not classified as a PARP inhibitor anymore. Initially, as you will remember in the phase 2 trial, there was a benefit for progression-free survival and overall survival, and everybody was very excited. However, the phase 3 study did not show a difference in progression-free survival and overall survival, so disappointing, just as an example of that agent. Ongoing studies in triple-negative breast cancer, I think very important in the neoadjuvant setting, looking at again, the regimen that was not successful, but in the neoadjuvant setting, carbopaclitaxel with sunitinib, the CLGB is doing a study. In the adjuvant setting, there's at least 3 or 4 major studies going on, and hopefully within the next 2 years, maybe, we will be able to give you, or I will be able to give you a little bit more information. So triple-negative breast cancer represents about 10 to 20% of breast cancer patients. It is associated with high proliferation, CK5/6, EGFR1 positivity, and the biology at this point is still poorly defined. We have another subgroup, Claudin-low, but beyond that, we really don't know that much. The PARP inhibitors are effective, but I think the ongoing studies will help us identify targets and better treatment pathways. Thank you very much for your attention.
Thank you very much, Professor Aron, for this very informative talk, but unfortunately no time for questions. I'm sorry.